Thank you, Shruti. We'll segue into the questions. First of all, a personal shout out to Dr. Bargman, who will remember me as an intern almost 40 years ago now. And it's lovely to have her as a guest speaker here. And the first question.
You spoiled me for everybody.
There you go. Never mind. I won't segue further than that. So yeah, but nephrology at the General, I very much benefited from, and did 6 months, and it was a lovely experience. So first question is for Shruti. How strong is the evidence supporting the use of steroid in ICIN?
So again, the evidence is from observational studies, but we do know that patients who are treated with steroids have a pretty high renal recovery rate. So within a week, patients do show response to steroids, and we showed that in our data. We also showed that 2/3 of the patients who were treated with steroids had kidney recovery, and patients who were treated faster with steroids also had kidney recovery compared to those who were treated slower. But again, a lot of the data that we have for steroids for kidney-related immune-related adverse events are derived from other studies of other immune-related adverse events. And as I mentioned, these patients end up having a lot of nasty side effects from the prolonged courses of steroids, which is why we're really trying to explore some steroid-sparing alternatives in this clinical trial.
Missed that last bit. Can you hear me? Okay. So one personal question I had, Shruti, and I had to deal with a patient issue, but are we underlying your rationale for biopsying your generic AKI with immune checkpoint inhibitor associated AKI? I know from the VA, we get a lot of pushback from the oncologists there who still remember the oncology position paper from several years ago, which was moderately unfortunate, to say the least.
Yeah. So I think that we've done a good job, at least here at our institution, of sort of changing the tune a little bit with regards to biopsy. And nowadays, we get very, very little pushback about pursuing a kidney biopsy because a lot of the oncologists really want to be able to continue their patients on therapy. And so they want to know the answer, particularly in these patients who are getting multiple other nephrotoxic agents at the same time, which we're seeing a lot more of, patients who are on dual immune checkpoint inhibitor and VEGF inhibitor, or patients who are on conventional chemo with the pemetrexed and the ICI, and they don't know which agent is causing the kidney injury. And so they've actually been much more supportive of performing the kidney biopsy. And fortunately, despite those oncology guidelines many years ago, which I agree were unfortunate, the SITC guidelines, which were published about 3 years ago, those ones actually did include a nephrologist, Frank Cortazar. And so those ones actually do now more strongly recommend a biopsy in patients where the diagnosis might be less clear.
Thank you. This one's for Dr. Bart. Oh, wait. Let's quickly, one more question for Shruti. Can we switch immunotherapy and try a different agent once AKI resolved? I would assume they mean another immune checkpoint inhibitor.
Yeah, it's a good question. So, buried deep in our supplement, we did actually look at whether switching the agent was associated with a lower, higher odds of developing recurrent kidney injury upon rechallenge, and that there did not appear to be a difference. We also have looked, generally at different types of ICIs and whether one is sort of more associated with AKI than another. And generally, there are not major differences across the different ICI types, although a number of studies have shown that combination therapy with 2 immune checkpoint inhibitors is probably worse than one, which is probably not too surprising. And so if a patient, for instance, had been on dual immune checkpoint inhibitors and developed AKI, we might counsel them to maybe stick with one the next time around upon rechallenge.
And the next question just popped up when is a good time to re-challenge immunotherapy after resolution of AKI?
Yeah, so generally we recommend waiting several weeks. The median time to re-challenge was, I believe, like 8 to 12 weeks following the ICI AKI episode. And that's because ideally you want to have some degree of kidney recovery, because we did look at those patients that were at higher risk for recurrent AKI afterwards, and the patients that had incomplete recovery were at higher risk for developing recurrent AKI. So you kind of want to give these patients the best shot at recovering, and ICIs also have very long half-lives. So you kind of want to give them a little bit of time to wash it out, clear everything up, and then re-challenge.
Okay. So the next questions are for Dr. Bargmann. Does the use of ACE inhibitor protect the peritoneum against fibrosis?
Interestingly, if you look at anatomy of the peritoneum, there are RAGE receptors and all of that on the peritoneal microcirculation. So there's at least a biologic plausibility that it might work. Having said that, there's very little good clinical evidence. There was one study about 15 years ago out of the Netherlands that showed that PD patients who were exposed to RAS inhibition seemed to have a better PET result compared to those who didn't. And that's about it. So it's like an intriguing biologic supposition, but it's never been proven. However, I personally have a low threshold to use ACE inhibitors. First of all, there's now 2 studies at least that have suggested that exposure to RAS inhibition in PD patients is associated with a survival benefit. And secondly, 2 small randomized controlled trials have shown that it preserves residual kidney function longer. So for those 2 reasons, I really have a low threshold. Sometimes their RAS has been stopped as they get progressive CKD because of hyperkalemia or whatever. And so, and they're on, let's say, a dihydropyridine calcium channel blocker instead. So we will very often switch them over from the calcium channel blocker to the RAS inhibitor once they're on PD. But, like I said, there's no good evidence that it preserves the peritoneal membrane.
Interesting. Next question. I have a patient with recurrent culture negative peritonitis found with a porcelain gallbladder. Surgery wants to remove the Tinkoff at time of cholecystectomy and switch to HD. Do you think the catheter should be removed or keep it and do low volume PD? That's a complicated question.
There's 2 questions there, actually. One is if you're taking out a gallbladder, do you have to take out the PD catheter at the same time? And the short answer to that is no. But here, I'd have to know more about the peritonitis, how recurrent it was, and whether they think it's tied in with the gallbladder. Does the person still have the peritonitis or not? So I don't know how to answer it without knowing more specifics, but the person's welcome to email me if they want with more details, and I can comment on that. So, I mean, just taking out a gallbladder, we've got a long experience now that you really don't have to take out the PD catheter at the same time. But I couldn't answer this without knowing more details.
Yeah, it sounded pretty granular. Do you prefer continuous administration of antibiotics over intermittent?
I preserve the ISPD, and we use intermittent antibiotics. The only time I go to continuous is if it's not getting better and I'm sort of pulling out all the stops, and it's kind of like a Hail Mary thing to try to switch them to continuous antibiotics, but hardly ever use continuous. Or just 99% of the time it's like once a day antibiotics.
Okay. Do you prescribe prophylaxis against fungal infection and prolonged antibiotic treatment?
Yes, I mentioned that in my talk, not just for peritonitis, but we have some patients, let's say with a necrotic infected toes from peripheral arterial disease, who wound care wants to put them on like 3 antibiotics for 6 weeks. And that really scares me. So yeah, we put them on prophylaxis.
Okay. Then the next question. how does one estimate KT over V from EGFR? Thanks.
Oh, I think that's renal. That's renal. You can do the calculation to it. It's just sort of an estimate, but the number I carry in my head is that for every mil per minute of residual GFR is equivalent to a renal KT over V urea of 0.2. And like I said, it's really not a valid. It's totally apples and oranges because for every 0.2 of renal KT over V, I think that's way better than 0.2 KT over V from PD or hemo. So you're underestimating, if you like, the contribution of the kidneys if you're just looking at renal KT over V urea. But just in terms of gaming the system, in terms of your having to report KT over V urea, that's why it's so important that you include the renal contribution, because with that, you can give the poor PD patient a less burdensome PD prescription.
Okay. And then the next question, I think we're getting close to the end here. One other question, can we use ACE-ARB to control blood pressure in dialysis patients? I think you answered that in terms of your own practice, but if you want to elaborate.
No, and we use a lot of it. And as you know, I mean, part of why we go nuts as nephrologists is that hemodialysis patients run into hyperkalemia and PD patients run into hypokalemia. So I see no worries about giving RAS inhibition to PD patients. And like I said, it does help preserve residual kidney function. There's an overall survival benefit that we don't know more about than just big numbers. And as we talked about a couple of questions ago, maybe theoretically it does something good to the peritoneal membrane, but that would be the least of my concerns in terms of the least of my rationale for using RAS inhibition. But so yeah, we use it all the time.
There are some concerns about patients on cycler PD may not get adequate antibiotic dose with once daily dosing because of clearance with frequent short dialysis compared to CAPD. Any thoughts on this?
I don't think it's a big deal. It seems to work quite well if you put the antibiotic in a longer day dwell during the day, even though you're like dialyzing it off at night. I don't think that there's like a worse response rate with APD than in CAPD.
Finally, the best question is for the last. Why is PD penetration low? And the local experience I can attest to over the last 3 decades. When I went to Vanderbilt, one of the Brigham trainees, Ray Hakim, was giving a talk. PD doesn't work and you know it. And I think we've slowly increased our own PD census, many thanks to Kevin Tucker. But I think the U.S. versus Canadian perspective and Toronto perspective is, I suspect, pretty important here.
As Sheldon said, a French nephrologist, he said peritoneal dialysis is second-rate therapy for third-rate patients carried out by fourth-rate doctors.
It's like violists. You must collect all these jokes, like the viola jokes in classical music. Anyways, keep going. Sorry.
No, that's why is it so underused in the United States?
Yeah.
I think it all starts with the training. I think, fellows come out of the program so much more comfortable with hemodialysis than they are with peritoneal dialysis. So you go with what you're comfortable with. And you also need an infrastructure to build a home dialysis program. So you need the infrastructure, and that takes a lot of work.
I think we're getting there for us. I think that's been a process, but certainly, I'm referring more and more octogenarian VA patients for PD, but there it's pretty much exclusively because they have the ability for assisted PD, which was also a huge advance for us. That if the daughter lives with them and can do PD, it's important. But we're getting there. We have Kevin has a pretty big clinic at DCI Faulkner, and we have a big clinic, of course, at MGH. So we're getting there, but nowhere near my experience as an intern at Toronto General. at any rate, we'll wrap up, and wonderful to see you, Joanne, in person.
You too.
And thank you, Shruti, for your talk as well.
Thank you.